Sure. My name's Claire. I'm a second year resident at Yale Primary Care Program. I've kind of been like I would call like a silent member of the community. I just sometimes log in. I listen to the podcast a lot. Um,
Yeah, well, so nice to meet you. Thanks you for joining us. And whether silent or vocal, everyone's a member of the community. So thank you for being here and presenting a case. We're super excited. Uh, Whenever you're all ready, yeah, we can get started. Go
yeah,
ahead, Clara.
give me 2 seconds. I'm gonna pull up the chart.
Sure.
Um, just because I need to find the exact details.
No worries. Maddie, do you want to take the first aliquot?
Yeah, that sounds great. And Clara, thank you so much again for jumping in to present.
Yeah, of course. Sorry, 1 second. It's here. Okay, here we go. Um, so this patient, the chief concern, I think was just weakness. Give me a second. Sorry, I'm coming back. It was from a couple of weeks ago. So I'm trying to find this. Okay, here we go. She presented, sorry, with some 5 days of fatigue, and also some difficulty with balance. No weakness, sorry. That resulted
All
in
right.
two.
Oh, go ahead, Clara. Sorry, I didn't mean to interrupt. I didn't know if you wanted to pause here or give some more data.
Yeah, can I give like I guess that we can do the history afterwards, but yeah. So she's an older person. So she's a 96-year-old woman, with overall not a huge medical history, but she's presenting with 5 days of fatigue, headache, and she had 2 falls at home.
Perfect. And okay,
Yeah.
we can stop here. Perfect. All right. Okay, so the information that Clara has given us is that this is an elderly woman, 96-year-old woman presenting with fatigue. And then I heard 2 falls and just kind of a general sense of imbalance, if I heard that correctly. So when I'm thinking of this kind of constellation of symptoms, I'm focusing on the falls because fatigue is more non-specific. And when I've heard of falls, I think I've learned from several people on VMR that you can think of falls as like the opposite or the inverse of walking. So you can think of what are all the things that need to coordinate in order to walk. And if any of those things goes wrong, then someone can fall. So specifically, if you think like, what does it take for us to walk properly? And there are 3 kind of buckets I think of, like the sensory input. So being able to sensory input from your eyes, from proprioception. From the sensory input, then you need to coordinate. And oftentimes that's in the brain, the cortex, the basal ganglia, the cerebellum. And then you have the motor output to like your legs and your feet for actually walking. So basically sensory input, coordination in the brain and the cerebellum, and then motor output. And so especially for this woman, I'm thinking where is the issue? Is it a sensory input issue? Is it a coordination issue in the brain, or is it a motor output issue? One important question I would have is during these falls, was there ever a loss of consciousness? Because that would kind of change how we're thinking about this. But yeah, high level kind of, is it a sensory, coordination, or motor issue? And really some key questions I would have are, was there loss of consciousness during these falls, and what was the circumstance? Like, was there some thing in her way, for example, that caused her to fall? So I would get a little bit more of a history, and if there was anyone around her when these falls happened. Sharmin, what are your thoughts when you are hearing this?
Yeah, I love that, Maddie. I especially love thinking fall opposite of walking. That's how I think about it as well. And as you mentioned, like so many things at so many different levels can, from like your sensory input to your cardiovascular system, can be on the hook. So, and especially in a 96-year-old woman, that differential just gets bigger, because I can only imagine, like, if she has like a URI symptom, or she hasn't been eating or drinking, like all of those things can contribute to like maybe a lightheadedness, sense of imbalance, and falls. So that's just to say that um this is like as broad as it gets. And I love your idea of like, it's kind of thinking about like what targeted questions to ask to be, hey, hopefully like narrow that framework a little bit, like thinking about what other accompanying symptoms that she has. And then your exam, your labs will be really informative. Because I totally agree. Right now, I would say like everything is on the hook, including medication side effects. So I would love to get some more information from Clara to see if we can make any progress.
This is a great beginning discussion. So on a little bit more review of systems, and a little more background. So on review of systems, she says that she's had 2 unwitnessed falls where she tripped, she became dizzy, she tripped, and she did hit her head. And then that was on the day of presentation. And that same day, she also had 2 episodes of non-bilious, non-bloody emesis and 3 loose stools. The other thing she endorses is some decreased appetite, and potentially some headache as well. This is from the initial H&P. On further review, after we were taking care of her, she had endorsed overall just feeling a little, her daughter and her endorsed it over the last month to 2 months. She had been feeling a bit more poorly. She had been having maybe some shortness of breath and some cough, but it was minimal. It was only with significant exertion. And she'd also had some weight loss, I think maybe 10 to 20 pounds, in the last few months. No fevers, no chills, no night sweats. She didn't pass out when she fell, and she didn't lose consciousness despite hitting her head. She doesn't report any like tachyarrhythmias or palpitations.
Clara, just for time's sake, do you want to just take us through up until the physical exam?
Totally. So her past medical history, she's 96, but she's overall quite healthy. She has a history of hypertension, hyperlipidemia, osteopenia. She's had a carotid endarterectomy, and she has prediabetes. That's it, despite being 96. She's lives independently. She's fully functional of all her ADLs. Her daughter thinks that maybe she might have a little bit of cognitive impairment, but nothing significant. In terms of her medications, she's a former smoker, but she quit 31 years ago. She doesn't use alcohol or other substances. Her medications, she's on allopurinol for gout, which also has history of gout. She's on amlodipine 10, her blood pressure. She's on aspirin 325. She's on atenolol, calcium carbonate as needed. Those are Tums. Zyrtec, vitamin D, vitamin E, and iron. One thing of note is that when she came in, she reported she'd had COVID at home and actually had been just given Paxlovid 4 days prior because she had a home positive test. I only bring that up as a side note. When she came in, she actually tested fully negative here 3 times, and we think it was not a real positive, but she had taken a couple days of Paxlovid at home. Her family history and all of the rest, that's not really relevant. She does report that she has no sick contacts at home. So in the emergency room, she was afebrile. She was sounding well. She was a little bit hypoxic to the high 80s. So she put her on 2 liters nasal cannula with good response. Her blood pressure was 124 over 111, over 58, sorry. And then her heart rate was 56 and her respiratory rate was 11.
All right, maybe we can pause there. And I'll just walk through the HPI and then see Maddie, what Maddie wants to add, and then leave the past medical history and a vital sign for Maddie to layer on. So just kind of going back to the fall. So we're like getting a little bit more clarity that it sounds like, in the background, there has been some like emesis, some loose stool that going on that could potentially paint a picture of poor PO intake or orthostasis as an etiology. So that is on my mind. So whenever I see someone elderly coming in with a fall, there's 2 things we want to figure out, right? Is there any consequences or from the fall itself, and then what caused the fall in the first place. So especially in an emergency room, those run parallel to each other. So from the fall itself, especially if he's having headache, making sure we do a very good neuro exam and we'll threshold to getting a non-conjugated CT, especially if she endures headaches and then maybe a head strike. I don't see like any anticoagulation on her field, but again, like as brain gets as we get older, our brain atrophies and some of those bridging veins are more more prone to traumatic tears. And then the other thing is like any fractures, especially older women most often have osteoporosis and oftentimes can have fractures that can hit pretty well. So doing a good survey becomes really important. So then how can we how the additional information that we've had so it kind of sounds 2 things are going on. One thing that is like is more acutely like few days of like something seems like GI symptoms, and in the background we also have this like weight loss that is going on. And in terms of like with the COVID test that may have been positive, is it like the GI symptoms related to COVID? Is it gastroenteritis? Is it something more sinister? And that's when the abdominal exam would be more informative, especially if you're thinking about like, non-gastroenteritis causes, like especially thinking about any like obstruction that require more urgent management, something to think about. And so for me, like again, like first step is like figuring out if she has any consequences of fall, and then like orthostatic vital signs would be helpful as an etiology of the fall, and then kind of figuring out where the GI symptoms are coming from. Maddie, what else do you have to add?
Yeah, I love that framework for falls. I'm thinking of what caused the falls and then what are the consequences. And I think Clara gave us a lot of information in the HPI that I'm still trying to tease out what is the center of gravity and what is the main thing that we're trying to solve. Because just to summarize, it sounds like the more acute issue are these 2 episodes of unwitnessed falls in the context of some loose stool, shortness of breath, and cough. But then more chronically, there's signs of inflammation with weight loss. So exactly as you said, Sharmin, there's kind of an acute component to this and then a more chronic. And some of the things I'm trying to tease out, so the patient recently tested positive for COVID, and Clara said that she's hypoxemic on exam. So I'm wondering, is the hypoxemia from the recent COVID-19 infection? And as Sharmin said, does the recent COVID infection explain kind of the loose stools and GI symptoms she's having? Another thing that people mentioned in the chat, especially with an elderly patient, polypharmacy is something you want to look out for, and drug interactions can really maybe something that can lead to falls. So I know just from like a family member experience that Paxlovid can have several drug interactions. So off the top of my head, I'm not sure if Paxlovid interacts with any of these, but that's something that I would be looking up to see if the recent use of Paxlovid is interfering with any of these meds that are causing either higher or lower levels and kind of causing some changes with her. And I'm looking to see if any of the medications that she's on could be contributing to her current presentation, especially when we're thinking about orthostatic hypotension, which I would be curious to see if Claire, if you got those vitals. But one of the things I always look at is the meds, and specifically beta blockers. And she is on a beta blocker here, so I would be curious, have there been any changes in the dose that she's on? And again, I'd be looking to see if there are any drug-drug interactions with Paxlovid. But as I said, just to kind of summarize, there's like an acute component to this and a more chronic picture. I'm still trying to figure out what to hang my hat on. One thing I did want to mention was the headache. And I think with the emesis and the recent falls, I'm concerned if there's some type of intracranial process here. We often separate headaches as kind of primary headaches versus secondary headaches. You know, primary headaches being the things like migraine, tension headache, cluster headache. And I think there are some red flags here that this could be a secondary headache. So I think getting a sense of the exam will help us hopefully make progress on what is the center of gravity of the case. Sharmin, any other thoughts?
No, that was wonderful, Maddie. And I totally, to be honest, missed the shortness of breath and cough. So thank you so much for pointing that out. And I totally agree that would be part of the acute. And, you know, when we get to the vital sign, and if she's truly hypoxemic, then I think that's a good place to start, is that if somebody's coming in with shortness of breath, cough, and hypoxemia, and thinking about of the workup of the hypoxemia itself, now without losing the sight of like the GI symptoms in the background and the fall as well. But I feel like, you know, in a case that, as you mentioned, there's so many different acute components, like trying to frame it around an objective finding, in this case, hypoxemia would be helpful. So sorry, I totally missed that. All right, Clara, do you want to give us some more information?
Yeah, of course. It's a great conversation. Learning a ton from you all working through this case. So on her exam in the ED and just in general, she's a very well appearing older woman. She was in no acute distress. She was on the 2 liters nasal cannula. Her neuro and HNT exam were pretty unremarkable. She did not have dry mucous membranes. And her heart was regular rate and rhythm. There was no murmurs that could be auscultated. Her abdomen was soft and tender, and there was no evidence of rebound or splenomegaly. Her poem was she had limited she had reduced like right-sided lung sounds in the lower lung fields, otherwise clear. And then her skin, she had a bruise over the side of her head where she'd fallen. Just to cut to the chase a little bit for timing, they did a CT head after she was admitted, which was demonstrated no evidence of a subdural or any acute bleeding. And there wasn't like any bone breakage either. In terms of her labs, I'm just gonna provide them for you. I think her white count, hemoglobin, and platelets were all within normal limits. But then on the interesting one was her CMP. Her sodium came back at 113. Her potassium was 4.3. Her chloride was 80. Her BUN was 0.6. And then her glucose was within normal limits. Sorry, her hemoglobin was low at 8.2, but that was chronic. I apologize. And then do you want the urine studies to go along with this? Regarding her urine studies, the urine, I'm sorry, I have to switch between all these different things. I apologize, to not prepare this properly. The initial serum osms was 247, so that's low. Her urine osms were 365. And her urine sodium was 54. She received in the ED almost a liter of normal saline with no improvement in her sodium. And then she was admitted to the ICU. There was one more thing that I can provide to you. I'm not sure if I should give it to you now or if you would like me that you would like to talk about this risk, and I can provide you one more imaging that was obtained.
Let's hold off for now. You've given us plenty to talk about. Clara, this is great. Thank you so much for presenting. Go ahead.
All right. So yeah, so we got the physical exam and the labs here. I think of course, what stands out on the physical exam is the reduced lung sounds on the right side, confirming there's some kind of pulmonary involvement. But then really the elephant in the room is the hyponatremia to 113. And I feel like I've learned that when you have hyponatremia, you want to ask, is it worth investing your time in? Because sometimes as internists, we see it a little low and we get really excited and we kind of jump to discussing it. But with a level that's 113, that is very severe hyponatremia, so something that we do need to explain. Before I kind of start going through the etiologies, I always try to ask about glucose because you need to correct it for hyperglycemia. And I didn't quite, oh, you said the glucose was normal. So we don't need to make any corrections there. But in order, like the way I think of hyponatremia, the first thing I look at is the serum osms, because that will allow us to bucket this as hypotonic, isotonic, or hypertonic. And I believe the serum osms were low. Is that right? It was,
Yeah, they were low.
perfect. Okay, so then we're in the bucket of the hypoosmolar hypernatremia. And then the next question I ask is basically, is this ADH mediated or not? And the next thing I look at then is the urine osms, because what ADH does is it concentrates the urine. So you would expect the urine osms to be high, which is what we're seeing here. So the way I'm putting those together, we're in the hypotonic hyponatremia. The urine osms are elevated, so then I'm thinking ADH is on board. And then the next question I ask is ADH acting appropriately or not? And my understanding is you can use the urine sodium to see if it's acting appropriately or not. If ADH is acting appropriately, it's acting in conjunction with aldosterone, and aldosterone reabsorbs sodium. So if it's acting appropriately, the urine sodium would be low. But I think in this case, the urine sodium is high. So to me, this is pointing to a picture, I believe, of SIADH. I would love Sharmin to correct me if I'm kind of going down the wrong path, but that's at least how I'm framing this. So I'm concerned about an SIADH picture. And then you can think of all the different things that are causing SIADH. And I think I would have to review kind of a framework for that. But I think a lot of things can cause that. Anything from like, pain, I think, can cause SIADH. But then one association I have is that certain types of lung cancer can cause SIADH. And now I'm thinking back to the physical exam, and this woman had decreased right-sided lung sounds, and she also has this picture of weight loss. So could she have a lung cancer that's causing SIADH that's leading to these falls? That's maybe one way to put this together. But I would definitely want to get some better imaging of the chest. So maybe like with a chest CT scan. Sharmin, what are you thinking?
That was incredible, Maddie. You just like walked into hypernatremia, like a hypernatremia to 113, and that was done really, really well. Uh, I'm shocked. Sodium of 113 is really, really low. And whenever I see hyponatremia that low, if this was an acute hyponatremia, she would be very symptomatic, right? Like I can't imagine someone acutely drop from the 130s to 113 without symptoms, without seizures. So there is definitely a component of chronicity to it. And you're absolutely right with the urine osms. It points to an inappropriate ADH, so SIADH most likely. I always wanted to be aware that sometimes sodiums can be multifactorial, while SIADH might be the most likely etiology if there's something else hiding in the background as well. And as we tread labs treat, that might become more evident. So let's say like, yes, we think this is SIADH, and the fact that she got 1 liter of fluid, if there was any component of like hypovolemic hypernatremia, I would anticipate a difference. The fact that it didn't change is also an important part of the clue. So I think this patient has probably some chronic hypernatremia that has made worse, but what is going on? So in terms of like etiology, you're absolutely right. SIADH can many things cause it. Pain, nausea, trauma are a weak one, especially with someone with like a fall, a head strike, thinking about TBI. I don't think this is quite like we worry about like cerebral assault wasting that you see post neurological procedures. So I'm not quite as worried about that. The one thing to also think about, like, we talked about CNS pathologies or like infectious syndromes that I'll come back to. There are some endocrinopathies like adrenal insufficiency and hypothyroidism can do it. So I think it's also fair in someone who's coming with fall, you worry about maybe component of orthostatic. Again, this is degree of hyponatremia does not make sense with that. It's usually much milder. However, if it's a double hit of adrenal insufficiency in addition to SIADH, possible. Cancer, you nailed it. Small cell lung cancers are the small cell carcinomas are the one that are most likely associated with SIADH. I mean, someone with a background of weight loss, lung findings, that is definitely high on the differential. In terms of like infections that I think about, virals like HIV can do it, zoster can do it, thinking about rickettsial. One respiratory one that comes that, fits perfectly with someone with, specific lung finding, hypernatremia, and GI symptoms is Legionella. So that's like a good one to to test for. And then granulomatous infections, also a possibility that can oftentimes associate with SIADH. And then again, like anything that can cause irritation of the lungs, we know like, regular pneumonias and stuff can cause it too. But those were like, I would like, my next step would be to get a CT chest imaging to better understand what is going on in the lung, test for some of these infectious etiologies, and have I worry that maybe it's a double hit model of like some malignancy in the background. And on top of that, maybe she has an acute infection that has made the SIADH worse. Any other thoughts, Maddie?
That was a brilliant breakdown of SAADH. I'm going to listen back to that. No other thoughts.
So, the next, I wanted some imaging of the chest. So they got a chest X-ray, which demonstrated a significant right pleural effusion. It was an X-ray. And then, would you guys like the rest of the course at this point? Okay. So she was admitted to us in the ICU. Nephrology was consulted because she needed hypertonic saline. We didn't want a central line, so we did an IV, propofol 1.5%. And then our team also was very concerned about this right-sided pleural effusion. In consultation with the daughter and the patient, we were able to convince them to allow us to do a thoracentesis, which we sent off for cytology and did a CAT scan after it, which demonstrated no clear mass, but maybe some like questionable consolidation. She was discharged after improving with the sodium on salt tabs and fluid restriction, a very strict, less than like 1 liter fluid restriction. And unfortunately, her cytology did come back consistent with malignancy. And she's now seeing oncology. I don't think that they're going to pursue treatment. The patient was very clear that she never wanted to have chemotherapies or anything like that. I suspect they're going to look for a targeted therapy if possible. Otherwise, I think the family and the patient would like to pursue hospice at that point. The reason I want to bring up this case is because, like you all were saying, it's like it was one of these cases where I got signed out. I was the person taking her up, and like the first thing I thought was there's something in her lung we need to know, and it's probably cancer. And it was like weirdly like a step 2 or step 1 question that turned out to be exactly right. Unfortunately, the good thing was that we were able to talk to the family before we got all this imaging and discuss that possibility, so they were prepared that this might be that. And the patient overall felt great. She got 1 dose of steroids in the ED because of her questioned COVID, which was negative. And she felt great after that. And she was very capable of returning back to her house and being comfortable there.
Thank you so much, Clara, for presenting this case. What a great case, and a presentation that we see not infrequently in a hospital, patients coming in with weak symptoms, then found to have another etiology like hyponatremia. And I'm so sorry about the cancer diagnosis, and I'm so glad the patient ended up doing better and was able to return home and to her independent living, because I know that's oftentimes where patients are so important. Thank you for taking such a great care of her and for sharing this. Just out of curiosity, what type of malignancy did it show?
Non-small cell
Interesting.
adenocarcinoma. They're trying to figure out exactly what type. She's seeing
Mm,
oncology now. They're doing like a PET scan because there wasn't a clear mass to sample.
yeah. Yeah, that makes a lot of sense. Oh, thank you for sharing. And yeah, with like a sodium that low, I think in terms of management, you nailed it. Like this patient needs hypertonic saline and very close monitoring. You don't want to correct it too fast, especially if it's chronic. And then once the level gets a little bit better, then the salt taps and fluid restrictions for SIADH usually gets it to a level. Sounds like, she wasn't terribly symptomatic from it to begin with, which kind of makes me marvel at the human body and what we can get used to. That sounds like it's been going on for a while. Maddie, any other thoughts from you?
Yeah, Clara, I just really want to thank you so much for bringing this case. There was just talking through this was really interesting because it started with, falls and an imbalance and ended up with severe hyponatremia. And so I thought you presented it in a brilliant way. And also your reflections at the end, especially someone who's 96, I think just as important, if not more important than kind of the diagnostic and management journey is kind of the goals of care discussion, the discussions with family members and the patient. And it seems like the patient was very lucky to have you as part of the team. And thank you for kind of talking about that aspect of the care as well at the end. I just want to clarify that. So that was the hyponatremia thought to mainly be from SIADH or some other
Yeah.
components contributing as well?
No, we think it was almost completely SIADH
From the lung cancer?
from the lung cancer.
Okay.
We're not sure if just lung cancer, but also the effusion. When you have any kind of like pulmonary pathology, it can contribute. So that was another reason to investigate the effusion. I don't think we tested for Legionella because we had a source at that point. And she did improve over slowly with it took some time. She very much went slow, required very strict fluid restriction and salt taps. Thank you
Thank you
so much.
so
It was
much,
really fun
Clara.
to listen to you guys discuss the case. It
You
was
did great job presenting. That was fantastic. And Maddie, like, wow, just you're amazing, my friend. Just absolutely brilliant. Uh, Jay, thank you so much for ascribing. And Mariana, we're ready for your teaching point. Thank you for doing teaching points.
Hello, everyone. Thank you, Clara, for this amazing case. Thank you, Sharmin and Maddie, for this amazing discussion. I'll try to be really fast here. So, our patient had fatigue and also a complaint of falls. And when you have a symptom like fatigue that is not a non-specific symptom, you should start with falls with the other one that is more specific. So what I learned today is that when you have fall, you can think about it in a positive walking. So you can think about sensory input, coordination, and motor output, and try to figure out what is the problem here. And something really important to ask is, were the falls associated with loss of consciousness? In this patient, it was not. And you also have to think about cardiovascular causes associated, if the patient had syncopes, or you also have to think about a medication side effect. And after a patient have a fall, you have to think about what caused the fall and what are the consequences of it. And it's important it's important to do a really good neural exam. You have to look for epidural or subdural hematoma signs, and also to look for fractures. And then we had more history of this patient, and the patient had a lot of complaints. And this moment is important to know what is acute and what is chronic for this patient. And we also discussed the gastrointestinal causes for hemesis and the importance of the abdominal exam. The patient also appeared with hypoxemia, and in this moment, we thought about COVID because the patient had a positive test for COVID at home, but it could explain the loose stools. And after we thought about headache associated with hemesis and fall, it could be due to intracranial cause. And in this moment, you have to think about secondary headache. And in the physical exam, the patient had reduced lung sounds and also severe hyponatremia. And it's more important to think about the severe hyponatremia here. And you have to check the serum osmolality and to figure it out if it's hypotonic, isotonic, or hypertonic, to know the cause of the hyponatremia. And if you have a patient with acute hyponatremia, the patient would be very symptomatic. In this case, the patient was not, so it was probably chronic. And we had a patient with hyperosmolar hyponatremia, and we started to think if ADH was associated, and we thought about the causes of SIADH. It could be due to lung cancer. It would make sense because of the lung fundus here, but it would need better characterization. And it also could be caused by neurological cause and endocrinopathies, infections. An important thing to remember here is the Legionella, because it could cause pneumonia associated with hyponatremia. And the diagnosis ended up being SIDH due to non-small cell adenocarcinoma.
Boom, Mariana, that was fabulous. Thank you so much for summarizing it so well. Gia, thank you so much for scribing. Clara, thank you so much for presenting the case. And Maddie, that hyponatremia discussion would make Jack so proud. Thank you all so much. See you next time. Thanks for joining us.
Bye, everyone. Thank you so much, Clara.